Welcome to the Week in Diabetes and Endocrinology from Hormone Insight. This podcast delivers a summary and perspective on the top news of the week that endocrinologists, diabetologists, and internists can't afford to miss. This podcast is intended for healthcare professionals. For the week ending April 10th, 2026, I want to talk about a Korean trial that finally settles the LDL target debate for our ASCVD patients, a Medicare policy earthquake that opens GLP-1 receptor agonist coverage for obesity, a second once-weekly insulin out of China that just beat both Glargine and Degludec, a network meta-analysis crowning CagriSema as the top obesity drug at the ACC, a post-hoc from Advance showing it's not your patient's blood pressure that predicts dementia, it's the variability, and a fascinating exercise study that says blood flow restriction training might be the mitochondrial reset our type 2 patients need. Let's get into it. So I want to start with what I think is the most practice-changing study of the week, and honestly one of the more important lipid trials we've gotten in the last several years. This is EZ-PAVE, published March 28th in the New England Journal of Medicine. And I'll tell you right up front, if you're still telling your ASCVD patients that an LDL under 70 is good enough, this trial says you're wrong. Here's the setup. This was an open-label, randomized superiority trial out of South Korea. 3,048 patients with established atherosclerotic cardiovascular disease, randomized to an intensive LDL target of less than 55 milligrams per deciliter versus a conventional target of less than 70. Median follow-up was 3 years, and the achieved LDL levels were pretty close to target median 56 in the intensive group versus 66 in the conventional group. So we're talking about a 10-point difference in LDL. The primary composite endpoint was cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, any coronary revascularization, and hospitalization for unstable angina. And the result: hazard ratio 0.67, 95% confidence interval 0.52 to 0.86, p equals 0.002. Event rate 6.6% in the intensive group versus 9.7% in the conventional group. That's a 3.1% absolute risk reduction, which gives you a number needed to treat of about 32 over 3 years. Let me put that in context. A number needed to treat of 32 over 3 years for a cardiovascular composite that is excellent. That's better than what we got from adding AZ-PAVE in IMPROVE-IT. That's in the ballpark of some of the landmark statin trials. And we're getting that benefit from pushing LDL down just 10 more points. Here's the thing, this wasn't a non-inferiority trial. This was designed as a superiority trial, and it hit superiority convincingly. The p-value was 0.002. The confidence interval doesn't come anywhere near crossing 1. This is clean. And what about safety? This is where it gets interesting. The adverse event profile was essentially similar between the two groups, except, and I love this, the intensive group actually had lower rates of creatinine elevation. Lower, not higher. So the old worry that we're somehow hurting patients by driving LDL into the 50s, this trial says no. Now, why does this matter so much for us in endocrinology? Because our patients are everywhere in that ASCVD population. The type 2 diabetic with a prior myocardial infarction. The patient with peripheral arterial disease and an A1C of 7.2. These are our patients, and EZ-PAVE tells us we should be targeting LDL under 55 for them, full stop. And look, this validates what the ESC has been saying since 2019. The European Society of Cardiology guidelines already recommend LDL less than 55 for very high-risk ASCVD patients. Meanwhile, the ACC and AHA guidelines still say less than 70. I think after EZ-PAVE, the American guidelines are going to have to catch up. The data are now too strong to ignore. So Monday morning, when you see your diabetic patient with ASCVD who's sitting at an LDL of 63 and you've been calling that at goal, reconsider. Push it below 55. Add EZ-PAVE if you need to. Add a PCSK9 inhibitor if you need to. The trial tells us the benefit is real, the safety is there, and the number needed to treat is compelling. Let's shift gears from pure clinical science to policy, because what CMS announced this week is, in my opinion, the single biggest policy development in obesity medicine in the history of Medicare. I'm not being hyperbolic. CMS announced the balance model that's better approaches to lifestyle and nutrition for comprehensive health, and the headline is this: Medicare Part D will cover GLP-1 receptor agonists for obesity starting in April 2026, as in now. Let me walk you through the details because they matter. Eligibility requires a BMI of 30 or greater plus at least one obesity-related cardiovascular comorbidity, so we're talking hypertension, type 2 diabetes, or prior major adverse cardiovascular events. CMS estimates that 3.4 million Medicare beneficiaries are newly eligible under these criteria. The rollout happens in phases. Starting July 2026, there's a bridging demonstration with a $50 per month copay for GLP-1 drugs. The Medicaid component launches in May 2026, and the full balance model under Medicare Part D goes live in January 2027. Now, why am I calling this a policy earthquake? Because until now, Medicare was explicitly prohibited from covering drugs for obesity. That's not a quirk that was written into the statute. So your 68-year-old Medicare patient with a BMI of 36 and a prior myocardial infarction who didn't happen to have diabetes, out of luck. That patient was paying out of pocket $1,000 a month or more or going without. That changes now, and the clinical implications are enormous. Think about your practice. How many Medicare-age patients do you see with obesity and cardiovascular disease who you've wanted to put on semaglutide or tirzepatide but couldn't because of the coverage barrier? But here's what bugs me: the budget implications are staggering. 3.4 million newly eligible patients times the annual cost of a GLP-1 receptor agonist, even with negotiated prices. The Congressional Budget Office must be losing sleep. There are real questions about whether the system can sustain this, whether supply chains can handle it, and whether we'll see utilization management barriers that effectively gatekeep access despite the policy change. And from an international perspective, the United States is now leading on obesity drug coverage, which is remarkable. Meanwhile, much of the world, including countries with universal healthcare, still can't get these medications to patients who need them. But on balance, no pun intended, this is the right call. The SELECT trial showed cardiovascular benefit. The evidence base is there. Denying effective therapy to Medicare patients with obesity and cardiovascular disease was never justifiable on clinical grounds. Okay, story number 3. And this one is about once-weekly insulin, and specifically about whether Novo Nordisk is about to have some serious competition. On March 31st, Gan and Li Pharmaceuticals out of China released results from 2 phase 3 trials of their once-weekly insulin called GZR4. The trials are Super 1 and Super 2, and the results are, frankly, impressive. Super 1 enrolled 588 insulin-naive patients with type 2 diabetes and randomized them to GZR4 versus insulin Glargine U100 with results at 26 weeks. The A1C reduction with GZR4 was negative 1.45% versus negative 1.22% with Glargine. That's a treatment difference of negative 0.23%, and it was statistically significant for superiority, not non-inferiority superiority. Super 2 was even more striking. This enrolled 631 insulin-experienced patients and compared GZR4 to insulin Degludec. At 26 weeks, A1C reduction was negative 1.00% with GZR4 versus negative 0.58% with Degludec, a treatment difference of negative 0.42%. Beating Degludec by 0.4% in A1C, that's not marginal, that's clinically meaningful. And here's what really caught my eye: 0 episodes of level 3 hypoglycemia in either trial, none in either group. Now, the big advantage GZR4 seems to have over Novo Nordisk's R-weekly, which we discussed last week on this podcast, is that GZR4 does not require a loading dose. With icodec, the 196-hour half-life means you need 3 weeks of loading to reach steady state. GZR4 apparently doesn't have that issue. And in a real-world primary care setting, simplicity wins. The obvious limitation: both super trials were conducted exclusively in Chinese patients. We need global trials. Pharmacokinetics can vary across ethnicities, and regulators outside China will require their own data. But here's the bigger picture. Is once-weekly insulin becoming a drug class? We now have Icodec from Novo Nordisk, GZR4 from Gannon Lee, and others in development. If this class matures the way GLP-1 receptor agonists did, from one-of-a-kind to multiple options with competition driving down price, that would be transformative for diabetes care globally. Section 4, and this ties back to something we discussed in episode 1 last week. At the ACC in New Orleans, a Bayesian network meta-analysis was presented that essentially crowned CagriSema as the top-performing obesity therapy we have. The analysis pooled 2,803 patients from randomized controlled trials comparing CagriSema, the combination of cagrilintide plus semaglutide, cagrihelintide alone, and semaglutide 2.4 mg alone, and CagriSema ranked first on every single efficacy endpoint. Weight loss, first. Waist circumference, first. A1C improvement, first. Fasting glucose, first. Systolic blood pressure, first. But here's the remarkable part. CagriSema also ranked best for GI tolerability. Less nausea, less vomiting, less diarrhea. Fewer discontinuations than semaglutide alone. Now, stop and think about that. In pharmacology, when you combine two drugs, you usually expect additive side effects. But CagriSema is breaking that rule. Better efficacy and better tolerability. The reason, I think, is the complementary mechanisms. Cagrilintide is an amylin analog. It works on satiety through amylin receptors, which are physiologically distinct from GLP-1 signaling. So you're hitting two appetite pathways without doubling up on GLP-1-mediated GI effects. This connects directly to what we said last week. I questioned whether dose escalation of semaglutide from 2.4 to 7.2 mg is the right strategy, or whether rational combinations make more sense. This network meta-analysis supports the combination approach. You get to a better place with fewer side effects by combining mechanisms rather than cranking one to its maximum. The Redefine trials in the New England Journal showed CagriSema achieving roughly 25% total body weight loss. That's bariatric surgery territory with a weekly injection. Novo Nordisk is expected to file for FDA approval in 2026. The combination era in obesity medicine is arriving. Section 5. This study probably won't make the front page of most medical news sites, but I think it's one of the most clinically important things published this week for anyone managing type 2 diabetes. It comes from the Journal of the American Heart Association, published March 31st, and it's a post-hoc analysis of the ADVANCE trial. The investigators took 9,586 patients from ADVANCE who had at least 5 blood pressure measurements over the first 18 months. And they asked, what predicts cognitive decline and dementia? 17.5% developed cognitive decline or dementia over 3.5 years. And the key finding, it was blood pressure variability, not mean blood pressure, not cumulative blood pressure load that predicted cognitive outcomes. Systolic blood pressure variability had an odds ratio of 1.11, confidence interval 1.05 to 1.17. Diastolic variability, same, odds ratio 1.11. Mean arterial pressure variability, odds ratio 1.13. Baseline pulse pressure, odds ratio 1.19. Meanwhile, mean blood pressure and cumulative blood pressure load were not significant. Why does this matter practically? We've been conditioned to think about getting to target. Is the patient below 130/80? But what this study tells us is that for cognitive protection in type 2 diabetes, the stability of blood pressure may matter more than the absolute level. Think about the patient whose blood pressure is 118/72 one visit, then 152/88 the next, then back to 124/76. Their mean is fine, but that swing is the signal for future cognitive decline. And not all antihypertensives are equal for visit-to-visit variability. There's literature suggesting calcium channel blockers and thiazide-like diuretics produce more stable blood pressure control than ACE inhibitors or beta blockers as monotherapy. So, for your type 2 diabetic patient at risk for cognitive decline, this might influence your antihypertensive class selection. It's a post-hoc analysis, so we should be appropriately cautious. But the biological plausibility is their recurrent hemodynamic stress to cerebral microvasculature, and the effect sizes are consistent. This belongs in your clinical reasoning. And finally, a rapid-fire gem from Cell Metabolism. This is about blood flow restriction training in type 2 diabetes. A 12-week randomized controlled trial compared blood flow restriction training, where you exercise with a cuff-restricting venous return against conventional resistance training in patients with type 2 diabetes. The bottom line, blood flow restriction training matched conventional training for muscle strength gains despite lower loads. But it uniquely improved muscle and adipose tissue, mitochondrial oxidative capacity, and increased mitochondrial content. The transcriptomic data showed blood flow restriction training activated angiogenesis pathways new blood vessel growth in trained muscle. And here's something practical. Blood flow restriction training preferentially reduced visceral fat and waist circumference, while conventional training tended to reduce subcutaneous fat. Visceral fat is the metabolically dangerous depot, so blood flow restriction training may be targeting the right fat. For the type 2 diabetes patient who can't tolerate heavy loads, bad knees, neuropathy, severe deconditioning, blood flow restriction training is emerging as a legitimate alternative with potentially superior metabolic effects. It's still a small study and needs replication, but the mechanistic data are compelling, and if you work with a physical therapy or exercise physiology team, this is worth putting on their radar. That's your week in diabetes and endocrinology from Hormone Insight. If you found this useful, share it with a colleague, and if you disagree with anything I've said, I hope you do, because that's how we get better. You can find show notes with all the references at hormoneinsight.com. Until next Thursday, keep questioning the evidence, keep learning, and keep putting your patients first. Thank you for listening.